Okay guys, so now we will discuss about the clinical histological types of ameloblastoma. The introductory part, clinical features, we are discussed in our first part, and treatment plan we will discuss in third part. Before that, I'll tell you a very beautiful definition by Robinson. According to him, he explained ameloblastoma in 5 terms, which can be remembered as one simple mnemonic, uniac. U is unicentric, it's centralized in one non-functional. I is talking about the growth, which is intermittent. A is anatomically benign and clinically persistent. Right. So let deep dive into it. Before discussing the histological pattern, I want to discuss about Vickers and Gorlin's criteria. What is Vickers and Gorlin criteria? According to Vickers and Gorlin, if you want to differentiate between neoplasia and non-neoplastic lesions, these 5 features must be present. How do you tell if it's a neoplasia or not? Based on these 5 features. What is Vickers and Gorlin's criteria? If you see tall columnar cells in your basal layer which are arranged in palisading pattern, and you see reversal of polarity of nucleus. Reversal of polarity means this is your normal cells look like, and our nucleus is always toward the basement membrane. If it's away from the basement membrane, it's a reversal of polarity. Arranged in palisading pattern. This is palisading arrangement when they are arranged in like wickets, like this. This is palisading nuclei. Hyperchromatic. Hyperchromatic means they are darkly stained, and subnuclear vacuole formation. When you see subnuclear means below nucleus, there formation of vacuoles. It is known as subnuclear vacuole formation. When you find cells like this in basal layer, it is a sign that this lesion is neoplastic. Now I'm going to discuss types of ameloblastoma. On the larger scale, we divided we divided ameloblastoma in 2 types largely. They are central and they are peripheral. Central is when they are on inside bone or basically intraosseous. Peripheral is when they're extraosseous, outside of bone. In central type, we have 2 types, unicystic and conventional, also known as multicystic. Right? Unicystic is when it's just one large cystic cavity. Multicystic is when you have multiple cavities like this, right? So in multicystic, if you have small multilocular, small lesions in multiple lesions, it's honeycomb appearance, right? And if you have one larger cavity divided by multiple septa, it's a soap bubble appearance. The multicystic type, based on his histological appearance, they're divided into 6 types. In one lesion, clinically, in one lesion, you can have more than one types. You can have part of tumor showing follicular pattern and part of tumor showing desmoplastic pattern. It's not necessary in one lesion you will find just one type of histological pattern, right? Same way in unicystic ameloblastoma, you will have 3 variants. We will discuss them how they are different. Okay, so I'll give you a very simple example, very simple mnemonic to remember them. For multicystic, you just have to remember PDF bag, PDF bag. How they are different? Let me tell you. For example, we have three different tumors, right? We know in tumor we have two part. In any tumor we have connective tissue and we have epithelial tissue. Epithelial is basically your tumor part. Connective tissue is normal, like your tumor won't be suspended in air. It has to be somewhere. It has to be placed in a connective tissue. What is below epithelium? It's connective tissue. There will be suspended in connective tissue. They're invasive, right? So in your plexiform, your tumor parts are mostly divided into, like there'll be appearance things, strings and multiple strands, right? If you see strands of tumor connective tissue, this is all pink, everything in pink is connective tissue, and in purple, this is your tumor cells. If they are thin strands, it's plexiform. It's plexiform. What happen in desmoplastic is, in desmoplastic, you have a lot of abundant of connective tissue. You have too much connective tissue, right? That is what desmoplasia mean. Desmoplasia mean increased amount of connective tissue. Your collagen fibers are way too much. What happens? These collagen fibers they compresses out. Like everything is connective tissue here. And what does it do? This connective tissue compresses your tumors into thin straight lines. In follicular, you will see islands of tumors. So in PDF, you will see variation between tumors, cells, and connective tissue. What happen in bag? In bag, you have extra features. You can see special features in all of them. What happen in basal cell? In basal cell carcinoma, your tumor cells will appear like thin sheets, spread out sheets. Each sheets represent, like they kind of give the appearance of basal cell carcinoma. There is no stellate reticulum in these cells. What happen in acanthomatous? Acanthomatous mean presence of spikes. What special you have is your creatine pulse. In granular, you have granules, multiple small granules. They've given a lesion, you just have to differentiate. It's from PDF or it's from BAG. If you see basal cell kind of lesion, it's a basal cell carcinoma, basal cell ameloblastoma. If you see creatine pulse, it's acanthomatous. If you see granules, it's granular. So if you see none of them, if there is nothing like this present, it's going to be from PDF. In PDF, you will just have to look. If it's multiple big islands, it's follicular. If there is strands, it's plexiform. If you see there's too much of connective tissue, too much of, sometimes given an appearance of hyaline cartilage. Too much of connective tissue, just desmoplastic. That's how easy it is, right? And then in unicystic, see, as the name suggests, it telling you that in the tumor you're going to see a large cystic cavity. Very easy. Accept it, it's a large cystic cavity. So where's the tumor cell? Tumor cell will be present on the periphery. Inside is just one cystic cavity. You don't have to look deep dive into it. There's nothing in the cavity, right? Outside the cavity, what you have? You have your connective tissue. This is your connective tissue. And this is your tumor cells, basically epithelium, ectomesenchymal cells, right? Now what you have to differentiate is, this is your lumen. If your cell's tumor is within the luminal wall, if in the luminal wall, it's a luminal unicystic ameloblastoma. If it's on the luminal wall. If the tumor is penetrated into the lumen, just like if it's grow inside the lumen like this is intraluminal kind of unicystic ameloblastoma, right? And in the third type, it is irrelevant of lumen. It's just tumor cells are just randomly lying around in connective tissue, right? Just like backbenchers, they have no idea what is going on in the class. They're just backbenchers. They're sitting around away from the lumen. They like, we don't care where the lumen is. They are mural kind of ameloblastoma. Mural unicystic ameloblastoma. So based on the location, you can tell what kind of tumor it is, right? So now we will discuss what is conventional multicystic or solid kind of ameloblastoma. So these are your multiple kind unicystic kind of ameloblastoma. You see this large. You can see there is one large region divided by multiple septa. So it's a soap bubble. This is very evident soap bubble appearance, right? This is honeycomb kind of appearance. We discussed in our clinical features. You can check out about all the clinical features about this conventional type. We are going to discuss the first type, which is follicular ameloblastoma. As I told you, follicular ameloblastoma, you will see a large islands, right? So this one is most common type of pattern in ameloblastoma. All of them, it's most common. What we will see in this? You will see islands of epithelium which resemble your enamel organ. Why? You will have outer side, you will have columnar cells, right? In between, you will have stellate reticulum cells, something like this. Outside, you will have epithelium cells. Inside, you will have stellate reticulum. Where do you find stellate reticulum? In your enamel organ, right? Sometimes what happen? These cells degenerated and form a large cystic cavity. This is cyst. That's why they know multicystic. The cyst will form in this case, right? So you will find in this you will find stellate reticulum cells, right? And sometimes these stellate reticulum degenerate and form cystic cavity. If you see, these are all cystic cavity, right? And in periphery, if you can see, there's cuboidal cells, and you can see palisading pattern. Even these you can see palisading pattern, right? In this here very clear. This is reversible polarity. This is your basement membrane, right? And you can see nucleus is opposite side of it. They are all columnar cells. If you have to draw it, just draw columnar cells. Put palisading pattern opposite to the basement membrane, right? In center, just make cystic cells, right? In center, either make a large cystic cavity or just make stellate reticulum. That's how easy you draw. And outside, just draw some threads. This is present clinical, and this is present to collagen fibers. You can make one or two vessels, some fibroblasts, and that's all. Easy. Your follicular cells is your follicular ameloblastoma is ready, right? These are all. This is cystic cavity. These inside you can see these are stellate reticulum cells. This is cystic cavity, right? In this also you can differentiate large cystic cavity, right? Large cystic cavity. These all are the patterns. The entire is like a one long island. This is an island. This is an island. So you can just look into it and tell it's a island. Yes. Plus there's cavity. Yes. Columnar cells. Reversal of polarity. Right. And in bit center stellate reticulum. It's a follicular ameloblastoma. I hope it's clear. Okay, so now we will move plexiform. What does plexiform mean? Plexiform mean long anastomosing pods or sheets, right? So in this, you can see this is your this is your tumor part. This is your ameloblastoma part. This is your tumor part. This whole. You can see in the follicular you have thick patterns, right? But in these, instead of islands, they are in strands, and everything else. This is all just connected tissue. This all is connected tissue. This all is connected tissue, right? This is your main tumor part. If this look like this, it's plexiform. In this, you will find cyst, right? This is cystic cavity. This one is cystic cavity. This one is cystic cavity. So in this also, you will find cystic cavity, right? Going to be stromal degeneration also, right? Like in this stromal degeneration is this side, this part is degenerated. Stroma is connective tissue. So connective tissue degenerated in this part. It's more of a degeneration rather than a cystic change, right? You will you will find columnar cells, plus you will find palisading patterns, plus you will find reversal of polarity, right? Everything is same. The main differentiator is presence of thick strands, right? Don't assume this is your tumor. This is your tumor, right? Do not look. This is not your tumor. This is your tumor. What I'm drawing in pink is in purple is your tumor. Don't assume this as a follicle. Like most of you will end up assuming this is an follicle, this is an island. No, this is not island. You do not see stellate reticulum inside it. There is no stellate reticulum cells. These are here. This is stellate reticulum kind of appearance. These are stellate reticulum cells. This is not inside of the follicle. This is outside of the tumor cells. This is connective tissue. This is the inside of the connective tissue. That's why this all is one thin strand. This all is one thin thick strand. Right? So this is your plexiform patterns of ameloblastoma. Third is acanthomatous. I told you what is the most beautiful thing of acanthomatous. The differentiator is keratin pearl. You will find rest of the things same here. Everything is same here. Like all the things except see this is one large keratin pearl. This is keratin pearl. This one is keratin pearl. Right? This overall appearance. This is how it's appear. Just same columnar cell, Vickers-Gorlin criteria still going to be followed. Columnar cells, reversal of polarity. This is your basement membrane. That's do not assume this as basement membrane. This is not your basement membrane. This is your basement membrane. Adjacent to your connective tissue. So you can see your reversal of polarity. Inside it, you have stellate reticulum. So it's still present in your enamel organ. But what special you have? Keratin pearls. So drawing it very easy, you just have to draw the follicular ameloblastoma and in between them you just have to add keratin pearls. Just give us small spiky shapes, keratin pearls. So it's always become a DD, sometimes it's just differentiated as squamous cell carcinoma or squamous odontogenic tumor. It's just sometimes represented squamous odontogenic. Next one is granular cell ameloblastoma. In this, what special you will find? Formation of granules. It's kind of eosinophilic granules, right? Why does these granules form? These granules are your lysosomal aggregation, right? And these forms because of activation of different proteins involved in lysosomal formation. And what happen? These increase your apoptotic activity, right? So that's why this region, this lesion is also a very aggressive lesion. It's very aggressive. Ameloblastoma is aggressive, but it is aggressive within the tumors, within the rest of the ameloblastoma, and there is very good chance of reoccurrence. How do we draw it? Everything is same. Normal follicular cells you have to draw. In centers, you just have to give small eosinophilic granules. These are your granules. In same, you can see these pinpoint granules. This whole is your granules. Same here. You draw same like follicular cells. You just draw the basement membrane, columnar cell, reversal of polarity, stellate reticulum cells, right? In between, you will draw some cells with granular formation. That's your granular cell ameloblastoma. Very easy. Follicular ameloblastoma with granules. If you follicular ameloblastoma keratin pulse become acanthomatous, follicular ameloblastoma with granule cells pattern, it's granule cell, it's become granular cell ameloblastoma. So it's very informative, very important, histopathological exam. Last is basal cell type of ameloblastoma. What special is this in basal cell ameloblastoma is you will find basal cell carcinoma feature. This is kind of analogous to your basal cell carcinoma. It is least common, very rare, right? What special you find? There is no stellate reticulum in this case. There is no stellate reticulum. In rest of them, you will find stellate reticulum. In this, there is no stellate reticulum. And if there is no stellate reticulum, so there is no cystic cavity. Instead of columnar, like sometimes what happen, your peripheral cells become cuboidal because there's too much of cellular pressure. So this is all your basal cell carcinoma. You see all of these cells and there is no stellate reticulum. This is just hyperchromatic cells, right? With thick nucleus. This is your basal cell carcinoma. Only diagnostic the thin sheets. You know how spread out like a sheets is there. If you see something like this, it's basal cell carcinoma. If you see it in islands, it's more towards the follicular type, but they just thick stains. There is no stellate reticulum, no cystic cavity, very easy to differentiate. Last is desmoplastic ameloblastoma. The desmoplastic ameloblastoma, what's special about this is in radiographically also it is radio opaque and radiolucent kind of lesion. It's radiolucency in which in deep down you will see radio opacity like this. It just gives the appearance of fibrous dysplasia. You look at this like this just fibrous dysplasia and nothing serious about it. You take the CBCT scan, just thick radiolucent lesion covered by radio opacity. There is inside the radio opacity. So hardly anyone will guess it's going to be ameloblastoma because it's very critical, very beautiful representation of fibrous dysplasia. But when you look into the radiographic appearance, you will see thin, thick amount of this is all everything in pink is your connective tissue, and these are your epithelial tumor cells. See how they are just squeezed in between, right? So these are your tumor islands. This kind of tumor you will find increased amount of tumor growth factor type beta. What happened because of that is increasing collagen in stroma, right? So it's kind of make everything give the appearance of hypocellular. Hypocellular means less amount of cell and hyalinize. Hyalinize is when there's too much of collagen. Increase collagen, decrease cells. When you see this, it's desmoplastic, right? So because of that, it's just squeeze your epithelium and squeeze epithelium give the appearance of thin strands. In this, you won't be able to make out SR cells. Stellate reticulum cells won't be able to make out. So only differentiator between you're going to confuse that is desmoplastic or plexiform. In plexiform, you can make out stellate reticulum cell, and in plexiform they are thick. In desmoplastic, they are thin, and you can't make out stellate reticulum. You can't make out, and it's going to be radiographically. It's going to be radiolucent, radio opaque kind of lesion. Plexiform is your radiolucent lesion, right? So with this conventional multicystic type is covered. I hope it's clear. Now we'll discuss unicystic type of ameloblastoma. It is intraosseous, we know. It's a kind of intraosseous region or a central region, right? There are 10% to 46% of recorded case. It's always less than multicystic, right? Multicystics are mostly from 54% to you can say 96% of the cases. Radiographically, you will see just one large cavity, luminal kind of ameloblastoma. This is your tumor cell. This is your lumen. This is your connective tissue. So if I draw, this is how it look like. This is your cystic cavity. This is your cells, right? And this is your whole your connective tissue, and this is your lumen. So this entire pic is this part, right? This is your cystic cavity. In this, what you find in this is luminal cavity confined by epithelial or tumor cells. Basal layer as always going to be either cuboidal or columnar. So they're talking about these cells. This is your basement membrane. So these cells are going to be cuboidal columnar with hyperchromatic nucleus, right? And subnuclear vacuolization. So Vickers Gorlin features will be there, right? So this is your luminal kind of unicystic ameloblastoma. In intraluminal, you will find same features, but your tumor is in a nodule, right? It's going to be a nodule growing inside lumen, and this growing lumen will give the appearance of Plexiform Unicystic Ameloblastoma. This is your luminal type. This is your intraluminal. Okay, and this is your mural. So this is your lumen, right? So this is your interluminal unicystic ameloblastoma. All of the features are going to be same as Vickers-Gorlin, right? Tall, columnar, cell, reversal of polarity, subnuclear vacuolization, everything going to be same. In this part, you will see plexiform pattern. In nodule, you will see plexiform pattern between the strands, thin sticks and thick strands. Everything is same. In mural kind of lesion, same features as shown, right? Same as only differentiator is tumor cells are in connective tissue as islands. This is your cystic cavity. This is your cystic wall, right? So these cells, these, right? This is your mural ameloblastoma, right? This is your mural ameloblastoma. Everything is same. You just have to write the Vickers-Gorlin criteria. Feature is same. Next is peripheral type of ameloblastoma. Peripheral is very uncommon, less than 10% of the cases of the all the ameloblastoma, right? It just arises from dental lamina under your oral mucosa. Histologically, it is same as intraosseous, same as intraosseous, right? Everything is same. Just middle-aged people mostly affected, right? Middle age, common in mandible, then maxilla, in gingiva. It's going to be painless, no ulceration. This is how it appears, just one thing. It's most of the time it's just assumed as fibroma, DD is mostly fibroma, epulis, right? All of the gingival swellings. If you take the radiograph or in the CBCT, nothing appear. Your bone will appear normal, but just a slight depression. This depression is due to pressure from tumor. See, that's the beauty of the tumor. Even though it's in the soft tissue, it's still compressing the bone. It still make it resolve. A slight depression will be present. You will find subtotal columnar cells, reversal of polarity, subnuclear vacuolization. Everything is going to be same as intraosseous. There is no difference, right? Only difference is peripheral. You will just find in soft tissue. There is no outside bone. Okay, just islands and all everything will be same. So with this, I sum up the ameloblastoma, clinical features of ameloblastoma. In the next class, we will discuss the treatment part. How do we treat the ameloblastoma? Thank you very much. We will meet again in next class.